as being associated with some hyperabsorption of calcium. That probably isn't a common problem anymore. It's most commonly iatrogenic. It's most commonly associated with manipulations of parenteral nutrition and our adjustments of TPN in small babies. It can also be due to congenital problems or other therapies, including the use of ECMO for reasons that aren't entirely clear, cardiopulmonary bypass, which is ECMO, or Williams syndrome. Next. So in terms of therapy, one of the problems that we have is that people will tend to take, when they see hypercalcemia, people will tend to take all of the calcium out of the TPN because they get a little nervous about that. Our preterm babies, as I indicated, turn over calcium very quickly. And so if you take out all of the calcium from the TPN, you will get hypocalcemia very quickly. So what you need to do is be a little bit more cautious and only decrease the amount of calcium in TPN rather than remove all of it. It's severe. Sometimes we have to use the same types of therapy that can be used in adults, including the use of volume expansion and furosemide. That's very uncommonly necessary. Every once in a while, somebody will try to use a bisphosphonate or some medical therapy. There's a traditional staging method that's used. It's not all that useful, but initially we see hypodense bones. This is an extremely difficult radiological finding. One radiologist or one neonatologist can look at a film and say the bones are washed out or hypodense or don't have much mineral in them. Another person can look at the exact same film and say they're normal. So what we're really looking for are classical changes of rickets that would occur in anyone else. And this includes abnormalities at the metaphyseal ends of the bone, this type of fraying or damage to the end of the metaphyses. You can see this kind of U-shaped curve here, which is called cupping of the bones, which is classic in rickets. And then in the most severe form, we have fractures, such as are seen here. Now, fractures in premature infants are often identified by chance. A radiologist will look at a chest x-ray taken for an entirely another reason and point out that the ribs are broken. Or someone will see a swollen arm on a premature baby and think that the bones are broken, obtain an x-ray, and sure enough there's a fracture. Our babies have small bones. Fractures occur with the routine care that they give, and a lot of times they will occur independent of actually having rickets. Well, what's the nature of the problem? Well, the problem is that human milk is a tremendous source of nutrients for premature babies, but it is relatively low in calcium. The human full-term baby does not need much calcium relative to the premature baby. In utero, the retention of calcium in the skeleton is about 100 milligrams per kilo per day. Human milk provides about 40. The absorption is about 70% of that, so the net amount retained is about 30 milligrams per kilo at best. Routine formulas, not designed for premature infants, are a little bit higher in calcium retention sometimes, but nowhere near the requirements of the baby. And TPN, at very, very best, gets you up to 70 to 80% of the requirements, usually less. In identifying the problem of rickets, in the United States, we mostly see this in a very small group of very small and very sick babies, which are babies that are less than 27 weeks or less than 1,000 grams birth weight, especially if they've been on parenteral nutrition for a long period of time. Especially those babies who have severe bronchopulmonary dysplasia bronchopulmonare, long-term steroid use, cholestasis, or fluid restriction. Now, there are biochemical tests which identify a baby as being at risk, but the ultimate diagnosis is by X-ray. In general, a very high alkaline phosphatase activity in the serum and a low serum phosphorus are sensitive but not entirely specific for an abnormal X-ray. In fact, the alkaline phosphatase activity can be completely normal, and you can have rickets, and we can have fairly high alkaline phosphatase activities and not have rickets. It's not generally a good idea to go around measuring parathyroid hormone or vitamin D levels. They're usually normal. They're expensive, and they don't provide much information. If you think the baby really needs or has a high risk of having rickets with a very high alk phosphatase activity or other clinical symptoms, then the baby needs an X-ray. La siguiente. In the United States, we fortify human milk, and we'll talk a little more tomorrow about human milk fortification, or use specialized preterm formulas for babies who are less than 1,800 grams birth weight, regardless of gestational age. There's some variability about that. There's some people who use transitional formulas for babies that are a little bit bigger. But in general, most babies under about 1,800 grams. Some places a little bit smaller, some places a little bit bigger will get premature formula. And babies over about 2 kilos, approximately, will be fed routine formula. The use of early trophic feedings, which was talked about by Dr. New, has been shown to have a lot of benefits, not the least of which is it actually decreases the peak alkaline phosphatase activity and is good for bones. La siguiente. Okay. Now, if we go back to the idea of calcium and getting enough calcium into the body of the premature infant, if we remember that the skeleton in utero gets about 100 milligrams per kilo per day of calcium, and we remember that the breastfed baby who's getting nothing but unfortified human milk retains about 30, with either fortified human milk or preterm formula, one achieves approximately the in utero levels. There is some variability about this. There are different forms of fortification that are used in different countries. Some of them have a little more calcium, some of them have a little less. The bioavailability in some places a little more, in some places it's a little less. Next. There are some differences in opinions about the targets, okay, for calcium intake. And here are a series of recommendations for target intake. So this is the recommended oral intake of calcium, phosphorus, and vitamin D. We're going to talk about vitamin D in just a minute, but it's on this slide also. So in the United States, we've generally targeted about 200 milligrams per kilo per day of calcium intake, with half of that being retained to get the net of 100 milligrams per kilo retained. European recommendations are somewhat lower for both calcium and phosphorus. Different consensus recommendations both in Europe and other ones will vary around a little bit. So there's no single consensus on recommendation. We're going to talk about vitamin D, but I just wanted to point out that the amount of vitamin D that's often given in the United States and Canada for premature infants is somewhat lower than is recommended in Europe, and we're going to speak about vitamin D now. Okay. Some people have advocated I don't know what that means. So some people have advocated directly supplementing minerals to human milk in addition to human milk fortifier preterm formula. It's currently used primarily for babies with alkaline phosphatase activities very high and radiological evidence of osteopenia. Rarely it's used with babies who have lower alkaline phosphatase activity and abnormal X-rays. In Europe, at times it's recommended to do this in place of human milk fortification. and that is that they will individually supplement micronutrients, calcium, phosphorus, vitamin D, protein as well for macronutrients. In the United States, we pretty much exclusively primarily use packaged fortification strategies. Occasionally, babies will need extra phosphorus separate from calcium. La siguiente. Here are some dosing that we've used. I don't think that these are too crucial to record. We're very cautious about the use of elemental calcium added to human milk. There's a rare case report of necrotizing enterocolitis with supplemental calcium added individually. These are very hyperosmolar, some of these solutions, and we don't know much about their bioavailability. But usually, so we go very cautiously, starting initially with about 20 milligrams per kilo of calcium and about half that of phosphorus, divided in 4 doses, and then fairly slowly going up to 50 milligrams per kilo per day of calcium and half of that of phosphorus. We do this extremely uncommonly. And the next part's not important. Next slide. Okay, I'm going to change topics just a tiny bit and talk about exercise for premature babies and whether or not that can be an important part of bone health. And this is in the literature a good bit, and I think it's just worth